You take that pill every morning. You have taken it for years. Maybe 3 years, maybe 7, maybe longer than you can clearly remember. Your doctor prescribed it, told you your blood pressure was too high, explained that high blood pressure damages the heart and the vessels and the kidneys, and handed you a prescription that you have been faithfully filling ever since. And your blood pressure came down. Partially. Sometimes. On good days, it looks reasonable on the monitor. On bad days, it spikes in a way your doctor cannot fully explain and calls unpredictable. And you go home and take your pill the next morning and wonder why something that is supposed to be under control keeps behaving like it is not under control at all. Here is what your doctor has never told you. Your heart did not decide to raise your blood pressure. Your heart does not set its own targets. Your heart does not independently choose to push blood through your vessels at dangerous pressure. Your heart receives instructions. Precise electrochemical instructions that arrive through your nervous system from a control center that sits not in your chest but between your ears. Your brain, the same brain that after 60 begins to deteriorate in ways that corrupt those instructions, that sends the wrong signals to the wrong vessels at the wrong intensity at the wrong time. That creates a pattern of erratic, treatment-resistant, unpredictably spiking blood pressure that your cardiologist manages with dose adjustments and calls the nature of the condition. It is not the nature of the condition. It is the nature of a brain that is struggling and a medical system that is not looking in the right place. Your blood pressure pill is managing a symptom. The cause is sitting in your brain untouched, unaddressed, and getting worse. And today, I'm going to show you exactly how that is happening, why it matters more than any blood pressure number your doctor has ever shown you, and what addressing the brain side of this equation could do for the years you have ahead. My name is Dr. Angela Whitfield. This channel exists to show you what a rushed appointment never will. Everything I share here is for educational purposes only and is not a substitute for professional medical advice. Please speak with your doctor before making any changes to your health routine, and drop your city or country in the comments right now. I want to know who is watching. I read every single one. Before I take you through exactly what your brain is doing to your blood pressure, I need to reinforce the concept that underlies everything on this channel, the brain first principle. Your brain is not just your thinking organ. It is your body's master control system. Every vessel, every heartbeat, every hormonal signal that determines how hard your blood pushes against your arterial walls. All of it runs under direct or indirect instruction from your brain. When your brain is healthy, those instructions are precise, coordinated, and protective. Your blood pressure rises when you need it to and falls when it should. Your vessels dilate and constrict in perfect response to demand. Your stress hormones activate when there is genuine threat and stand down when the threat has passed. When your brain begins to deteriorate after 60, those instructions become corrupted, not all at once. Not in a way that shows up on a memory test or a cognitive assessment early on, but in a way that shows up in your blood pressure readings, in the spikes that come out of nowhere, in the resistance to medication that makes your cardiologist adjust your dose again, in the cardiovascular events that happen to people whose blood pressure was being treated and supposedly managed. Your doctor is treating the pressure in the vessels. Nobody is treating the brain that is setting that pressure. Keep the brain first principle with you as we go through everything I am about to show you. Let me tell you about Raymond. Raymond was 69 years old, a retired firefighter from outside of Cleveland, Ohio. Built man, disciplined his whole life, never smoked, rarely drank, stayed active well into retirement. He was proud of the fact that he had never needed much medication. Then at 64, his blood pressure started climbing. His primary care doctor started him on lisinopril, a standard ACA inhibitor. It brought the numbers down reasonably well for about 8 months. Then the readings started drifting up again. His doctor added a calcium channel blocker. Better for a while, then the spikes started. Not constant high pressure, erratic pressure. A reading of 140 over 88 in the morning and 170 over 102 in the afternoon with nothing obvious to explain the difference. His cardiologist called it labile hypertension, variable blood pressure, difficult to control in older adults. He was given a third medication. He was told to monitor at home and call if anything alarming happened. Raymond was also noticing other things over the same 5 years. A shortening of his patience that his wife described carefully one evening as, "You just do not seem like yourself lately." A difficulty sleeping that had him awake between 2 and 4, most mornings staring at the ceiling. A mental slowness he tried to dismiss, but could not ignore when he found himself reading the same paragraph in his newspaper 3 times and still not fully absorbing it. None of his doctors had ever put Raymond's blood pressure file and Raymond's cognitive observations in the same room at the same time.
They were separate concerns in separate departments, and in that separation, the most important part of Raymond's story was going completely unexamined. Here is what the research shows about the brain and blood pressure regulation that the standard cardiology workup is not designed to assess. There are 5 specific mechanisms through which a deteriorating brain directly drives hypertension in adults over 60. Each one of them represents a failure point that no blood pressure medication currently addresses. Each one of them is addressable in ways that your prescription bottle is not reaching. Mechanism number 1, the hypothalamus and the broken blood pressure thermostat. Deep inside your brain, in a structure called the hypothalamus, sits what is essentially your body's blood pressure thermostat. The hypothalamus continuously monitors blood pressure through signals received from baroreceptors, pressure sensors located in your major arteries. When pressure rises too high, the hypothalamus sends signals through the autonomic nervous system to dilate vessels, slow the heart, and reduce cardiac output. When pressure drops too low, it does the opposite. In a healthy brain, this feedback loop is precise and rapid. Blood pressure stays within a tight, healthy range. When the hypothalamus is affected by neuroinflammation, by the early structural deterioration associated with cognitive aging, by the chronic sleep disruption that accelerates brain aging in older adults, this thermostat becomes miscalibrated. It reads normal pressure as low pressure. It sends signals to raise blood pressure when no such elevation is needed. The vessels constrict inappropriately. The heart pumps harder than the situation demands, and your blood pressure climbs. Your cardiologist prescribes a medication that forces the vessels to relax. The thermostat sends a stronger signal to compensate. You need a higher dose. The thermostat adapts again. This is not a cardiovascular problem that medication is failing to solve. This is a brain problem that medication was never designed to address. A landmark review published in Hypertension in 2021 concluded that central nervous system dysregulation, specifically hypothalamic dysfunction, is an underappreciated and underinvestigated driver of treatment-resistant hypertension in older adults, and that cardiovascular-focused treatment protocols are structurally inadequate for addressing the neurological component of blood pressure dysregulation. Underinvestigated, structurally inadequate. Those words are in a published cardiovascular research review, and your cardiologist's protocol has not changed because of them. Mechanism number 2, chronic neuroinflammation and arterial wall destruction. We discussed neuroinflammation in the context of swollen legs in a previous video on this channel. But what neuroinflammation does to your arterial walls is even more directly dangerous and even less discussed. When microglia, your brain's immune cells, become chronically activated, they release inflammatory cytokines into the systemic circulation. Those cytokines travel to the walls of your arteries throughout your body. They trigger inflammation in the endothelium, the single-cell thick inner lining of your arterial walls, that is responsible for producing nitric oxide. Nitric oxide is the molecule that keeps your arteries relaxed, flexible, and able to dilate in response to increasing blood flow. When endothelial inflammation suppresses nitric oxide production, your arteries lose their flexibility. They stiffen, and stiff arteries cannot dilate to accommodate increasing blood flow. Blood pressure rises not because the heart is pumping too hard, but because the pipeline has become rigid and cannot expand. Your cardiologist measures the stiffness, labels it arteriosclerosis, prescribes accordingly. But the inflammatory signal that created the stiffness originated in the brain. A 2022 meta-analysis published in the European Heart Journal found that neuroinflammatory markers, specifically interleukin-6 and C-reactive protein at levels associated with central nervous system inflammation, were significantly predictive of arterial stiffness progression in adults over 65 independent of traditional cardiovascular risk factors. Independent, meaning even after accounting for cholesterol, smoking, diabetes, and obesity, brain inflammation was still independently driving arterial destruction. Your cardiovascular risk profile did not capture it. Your brain was the variable nobody measured. Mechanism number 3, the cortisol flood and the heart that never gets to rest. Your brain manages your stress response through the hypothalamic pituitary adrenal axis, a chain of command that runs from the hypothalamus in the brain to the pituitary gland to the adrenal glands sitting on top of your kidneys. When your brain perceives threat, whether real or misperceived, due to neurological deterioration, the hypothalamus initiates a cortisol release. Cortisol is a powerful stress hormone that raises blood pressure, increases heart rate, constricts blood vessels, and mobilizes energy reserves to prepare the body for threat response. In an acute situation, this is protective. The threat passes, cortisol clears, blood pressure normalizes. In an aging brain that is increasingly prone to misreading neutral situations as threatening, that initiates stress responses in the middle of the night during fragmented sleep, that maintains a low-level cortisol elevation virtually constantly due to hypothalamic miscalibration. The result is a cardiovascular system that almost never fully rests. Your heart works at elevated output for hours every day in response to threats that do not exist. Your vessels maintain constriction that serves no protective purpose. Your blood pressure sits persistently higher than it should because your brain is running an emergency protocol in the absence of any emergency. A 2020 study published in the Journal of the American Heart Association found that chronically elevated cortisol levels in adults over 65 were associated with a 42% increased risk of hypertensive crisis events and a 38% increased risk of major adverse cardiovascular events over a 5-year follow-up period. 42%. For a hormone whose dysregulation originates in the brain and whose management is not included in any standard hypertension treatment protocol. Mechanism number 4, sleep fragmentation and overnight blood pressure disaster. In a healthy cardiovascular system, blood pressure follows a predictable daily pattern. It rises in the morning as you wake and prepare for activity. It remains elevated during the day in proportion to your activity and stress levels. And critically, it dips during sleep, typically by 10 to 20% below daytime levels. Researchers call this the nocturnal dip. And the nocturnal dip is not a passive phenomenon. It is an actively orchestrated cardiovascular recovery period during which your heart repairs micro-damage from the day's exertions, your arterial walls restore elasticity, and your entire circulatory system resets for the following day. This nocturnal dip is governed by the brain, specifically by the autonomic nervous system changes that accompany deep, slow-wave sleep. When sleep is fragmented, when deep slow-wave sleep is absent or severely reduced as it chronically is in adults over 60, with any degree of brain aging, the nocturnal dip disappears. Blood pressure stays elevated through the night. The heart never gets its recovery window. The arterial walls never fully restore. And over months and years of non-dipping sleep patterns, the cumulative cardiovascular damage is profound. A 2023 study published in the Journal of the American College of Cardiology found that non-dipping blood pressure patterns in adults over 60 were associated with a 61% increased risk of cardiovascular events and a 54% increased risk of cognitive decline over a subsequent 8-year period compared to normal dipping patterns. 61% increased cardiovascular risk, 54% increased cognitive decline risk, from a sleep pattern driven by brain aging, that your blood pressure medication does nothing to address. Type yes in the comments right now if your doctor has never once asked about your sleep in the context of your blood pressure. I read every single comment. Mechanism number 5, the renin-angiotensin system and the brain's secret blood pressure lever. This is the mechanism that your blood pressure medication is most directly attempting to address. And understanding why it keeps failing requires understanding where the control of this system actually sits. The renin-angiotensin-aldosterone system is a hormonal cascade that regulates blood pressure through kidney function, fluid retention, and vessel constriction. ACE inhibitors, the most commonly prescribed class of blood pressure medication, work by blocking a key enzyme in this cascade. What is almost never explained to patients is that the renin-angiotensin system has a parallel component that operates entirely within the brain itself. The brain has its own local renin-angiotensin system that regulates blood pressure independently of the peripheral system your medication is targeting. When the brain's local renin-angiotensin system becomes dysregulated due to neuroinflammation and neurological deterioration, it drives blood pressure elevation through mechanisms that peripheral ACE inhibitors do not reach. Your medication blocks the enzyme in your bloodstream. The brain continues driving pressure through its own internal system that the medication was not designed to touch. A 2019 study in hypertension research found that brain renin-angiotensin system dysregulation was a significant independent contributor to treatment-resistant hypertension in older adults, and that treatment protocols that do not address the central nervous system component of blood pressure regulation are structurally incomplete for this population. Structurally incomplete. For the population that most hypertension medication is prescribed to. Here is what you can do about the brain side of your blood pressure that your prescription is not addressing. These are 5 interventions that work at the neurological level of this problem. Intervention 1. Protect your nocturnal blood pressure dip with sleep. Everything I said about sleep in the swollen legs video applies here with even greater cardiovascular urgency. Consistent sleep and wake times. Bedroom temperature 60 to 67 degrees Fahrenheit. No alcohol within 3 hours of bed, because alcohol is one of the most potent eliminators of the nocturnal blood pressure dip that exists. It keeps your cardiovascular system activated through the night in a way that compounds every single cardiovascular risk you already carry. No screens 1 hour before bed, and speak to your doctor specifically about whether your blood pressure has ever been monitored overnight. A test called ambulatory blood pressure monitoring to determine whether you are a non-dipper. If you are a non-dipper and your treatment protocol does not account for it, your medication timing may need to be adjusted specifically around restoring the nocturnal dip. Intervention 2. Reduce neuroinflammation through the dietary choices that directly affect your arterial walls. Eliminate refined vegetable oils from your cooking entirely and replace them with extra virgin olive oil. The oleocanthal in extra virgin olive oil suppresses the same inflammatory enzymes as anti-inflammatory medications through a mechanism that directly protects endothelial nitric oxide production. Your arteries become more flexible. Your blood pressure has more room to move. Add fatty fish 2 to 3 times per week for EPA and DHA omega-3 fatty acids that reduce the circulating cytokines attacking your arterial lining. Add beetroot or beetroot juice to your diet 3 to 4 times per week. Beetroot is one of the richest dietary sources of inorganic nitrate, which your body converts to nitric oxide directly in the bloodstream. Multiple clinical trials have shown that regular beetroot consumption produces blood pressure reductions comparable to low-dose antihypertensive medication in older adults through the nitric oxide pathway that neuroinflammation is suppressing. Reduce refined sugar aggressively because blood glucose spikes directly suppress nitric oxide production in the endothelium within minutes of occurring. Every spike is a direct hit to your arterial flexibility. Intervention 3. Aerobic exercise as the most powerful blood pressure intervention available. 30 minutes of moderate aerobic exercise 5 days per week produces sustained blood pressure reductions that in multiple clinical trials have been comparable to or exceeding those produced by single antihypertensive medications. The mechanism is multiple and direct. Exercise stimulates nitric oxide production in the endothelium. It reduces circulating inflammatory cytokines. It improves autonomic nervous system function and hypothalamic calibration. It reduces cortisol reactivity by training the HPA axis to respond more proportionately to stress. It improves sleep quality and restores the nocturnal dip. Every single one of those effects addresses a mechanism driving your hypertension from the brain side. Your cardiologist may have mentioned exercise. Almost certainly they did not explain it through the brain mechanisms that make it work. Understanding why it works is what motivates consistent application. Walk for 30 minutes, 5 times a week. For your brain first, your blood pressure will follow. Intervention 4. Address your cortisol load directly. This is the intervention most consistently overlooked in hypertension management for older adults. Chronic psychological stress, social isolation, persistent anxiety, and unresolved grief or loss all sustain HPA axis activation and maintain the cortisol elevation that keeps your blood pressure high and your heart working through the night. This is not a soft lifestyle recommendation. Cortisol management is cardiovascular medicine. The data on the relationship between chronic psychological stress and cardiovascular mortality in older adults is unambiguous. Specifically, evidence-based stress reduction approaches including mindfulness-based stress reduction, which has been shown in multiple randomized controlled trials to produce significant reductions in both cortisol and blood pressure in older adults. Tai Chi, which simultaneously reduces cortisol and improves autonomic nervous system function in a way that directly restores blood pressure regulation and meaningful social engagement. Because social isolation in older adults is associated with cortisol elevations comparable to those produced by acute psychological trauma. These are not suggestions for feeling better. They are interventions for a cortisol-driven hypertension mechanism that your pill does not reach. Intervention 5. Have the brain conversation at your next cardiology appointment. Ask your cardiologist whether the neurological component of your blood pressure regulation has ever been evaluated. Ask whether ambulatory blood pressure monitoring has been used to determine whether you are experiencing a nocturnal dip. Ask whether your inflammatory markers, including interleukin-6 and high-sensitivity C-reactive protein, have been measured alongside your standard cardiovascular panel. Ask whether any cognitive assessment has been included in your hypertension workup, given the published evidence linking brain aging to treatment-resistant hypertension. These questions do not challenge your doctor's competence. They expand the frame, and any physician who is genuinely solving your blood pressure problem rather than managing your readings will welcome them. I want to close with this. Raymond, the retired firefighter from Cleveland, 5 years of 3 medications and readings that still would not fully cooperate. He eventually asked his doctor, not a specialist, just his primary care physician, whether his brain had ever been considered as part of the blood pressure picture. His doctor paused, really paused, and said honestly, no. They ordered an inflammatory panel. They did an ambulatory blood pressure monitor that confirmed complete absence of nocturnal dipping. They did a cognitive baseline assessment that revealed changes nobody had measured before. Raymond's treatment changed. Not his medications initially, his sleep, his diet, his exercise, his stress. Within 4 months, his nocturnal dip had partially returned. His daytime readings were more consistent and less erratic. His cardiologist was able to reduce one of his 3 medications, and Raymond told his daughter that for the first time in 5 years, he felt like somebody had finally looked at the right thing. His heart was not the problem. His heart was the one paying for it. His brain was where it started. And his brain was finally where the treatment was pointed. Your blood pressure pill is doing something. It is not doing everything. The part it is not doing is the part that started this. And the part that started this is in your brain. You now have 5 mechanisms that explain exactly how. You have 5 interventions that work at the level your prescription cannot reach. And you have the questions to take into your next appointment that could change the entire direction of your treatment. If this changed how you understand what is really happening in your body, please subscribe. This channel exists to show you what a rushed appointment never will. Share this with someone whose blood pressure has been treated for years without fully cooperating. What you share today might change what they ask at their next appointment. Leave a comment below. Type yes if your cardiologist has never once mentioned your brain. Tell me how many years you have been managing your blood pressure. I read every single one. This is Dr. Angela Whitfield, and I will see you in the next one.